Very good morning, everyone. Dr. Hamid is here. Today we are going to talk about cholinergic antagonists. Cholinergic antagonists are chemicals or drugs which can decrease the effect of acetylcholine in the synapses. We know these cholinergic antagonists as anticholinergic drugs. Another name for cholinergic antagonist is parasympatholitic drugs. Parasympatholitic drugs. These cholinergic antagonists, anticholinergic or parasympatholitic drugs, all they have one mechanism of action. The mechanism of action for these drugs is shown here. Imagine that this is muscarinic or nicotinic receptors. When we use anticholinergic drugs, these anticholinergic drugs can compete with acetylcholine for binding to the active site of muscarinic or nicotinic receptor. They occupy the acetylcholine site. By occupying the acetylcholine site, acetylcholine is not able to bind to its receptor, and the effect of acetylcholine in the cholinergic fiber will decreases. Now, on the basis of the receptor types, if these chemicals bind to the muscarinic receptors, those are anti-muscarinic drugs, and if they bind to the nicotinic receptor, you know about nicotinic receptor. We have nicotinic receptor in the ganglion. We have nicotinic receptors in neuromuscular junction. If they bind to the nicotinic receptor in the ganglion, those are ganglion blockers. And if they bind to the nicotinic receptor in the neuromuscular junction, those are neuromuscular blockers. So how do we classify cholinergic antagonists? On the basis of the receptor types, we can classify these drugs into anti-muscarinic drugs. The second class is ganglion blockers. Ganglion blockers. They block the nicotinic receptor in the ganglion. And the third group is neuromuscular junction. Neuromuscular blockers, and they blocks the nicotinic receptor in the neuromuscular junction. We are not going to talk about ganglion blockers and neuromuscular blockers in this lecture. We'll talk about these two group of drugs in next lecture. We will only talk about anti-muscarinic drugs in this lecture. Anti-muscarinic drugs, as I explained, they block the muscarinic receptors. All we know that we have 5 subtype of muscarinic receptor, M1, M2, M3, M4, and M5. These anti-muscarinic drugs, they can block all 5 subtype of muscarinic receptors. So they can act centrally as well as peripherally. These anti-muscarinic can act centrally as well as peripherally. It means that they can block the central receptor, the receptor which are located in the central nervous system, as well as they can block the receptor which are in the periphery. For example, the receptor which are on the heart, in the GI system, and the eye, they can block. The prodrug in anti-muscarinic drugs is atropine. We will study the characteristic of anti-muscarinic drugs in atropine. So the prodrug is atropine. The prodrug in this class is atropine. Atropine is a tertiary amine which can act centrally as well as peripherally. It means that it can block all 5 subtype of cholinergic receptor. Act peripherally and centrally. Okay, if it blocks the M1 receptor, which we have in gastrointestinal system, if it blocks the M1 receptor, which is in the GI system, it can decrease the secretion as well as it can decrease the movement of or the motility of the gastrointestinal system. So by blocking the M1 receptor in the GI, it can decrease the secretion as well as it can decrease the motility. By decreasing the motility, we can use atropine for treatment of spasm, and it shows antispasmodic effect. Antispasmodic effect. And by decreasing the secretion, we can use this for its anti-secretory effect. Anti-secretory effect. This is one of the action of atropine when we use or when we prescribe it for any patient. If it blocks the M2 receptor, which is located on the heart, okay, when we give atropine can bind to two subtype of receptor. It can bind to the M1 receptor, it can bind to M2 receptor. If it binds to M1 receptor, it can decrease the heart rate. It can slightly decrease the heart rate. It slightly decrease heart rate. But when it binds to M2 receptor, it can, all you know that M2 receptor is an inhibitory receptor. It has inhibitory effect. When atropine binds to M2 receptor, it blocks the M2 receptor, so the effect will be opposite. It can show excitatory effect and it can increase the heart rate. It increases heart rate. And these two effects on the cardiovascular system, I mean, when it binds to M1 receptor, it decreases the heart rate. When it binds to M2 receptor, it increases the heart rate. It is dose dependent. This effect is dose dependent. It means that when we give it in lower doses, in low doses, it can decrease the heart rate. When we give it in higher doses, it can increase the heart rate. So this effect is dose dependent. And we can use atropine for treatment of bradycardia. On the basis of this effect, we can use it for treatment of bradycardia. This was the second action of atropine. When we give atropine to any patient and it binds to M3 receptor, all we know that we have M3 receptor on the glands, we have M3 receptor on smooth muscles also, we have M3 receptor on the eye also. When it binds to the M3 receptor on the eye, it can block the M3 receptor and it can cause mydriasis, as well as it can cause cycloplasia. On the basis of this effect, we can use atropine for measurement of refractory errors. Measurement of refractory errors. But there is some problem with atropine when we give it for measurement of refractory error because of its long duration of action. When we give atropine for this purpose, the duration of action for atropine is 72 hours. Because of this long duration of action, we do not use atropine for this indication. Instead of atropine, we can use some other drugs which have short duration of action. For example, we can use tropicamide. We'll talk about these drugs. We can use tropicamide as well as we can use another drug which is cyclopentolate. We can use these drugs for measurement of refractory errors. If we give atropine to any patient, atropine, as I explained, it can bind to some other receptors also, and it can block the other subtype of receptors. For example, if it binds to the M3 receptor, which are located on the glands, M3 receptor and the glands, it can decrease the secretion. It decreases the secretion. If it decreases the secretion of salivary gland, it can cause xerostomia. It can decrease the secretion of lacrimal gland secretion decreases, as well as it can decrease sweating also. When we decrease the sweating, the temperature will increases, the body temperature will increases, and that will lead to hyperthermia, which is dangerous for children as well as elderly patients. It will cause hyperthermia, which is dangerous in children and elderly patients. So atropine is contraindicated for children and elderly patients because it can cause hyperthermia. This was the action of atropine when we give it to any patient. The second thing that we will study is about the indication of atropine. We can give atropine for its anti-secretory effect. We can give atropine for anti-spasmodic effect. We can give atropine for treatment of bradycardia. We can give atropine for measurement of refractory errors, but instead of atropine nowadays, we are using tropicamide and cyclopentolate. We can give atropine as antidote of some drugs also. Antidote of some drugs, I will write here, antidote. Do you remember we talked about acetylcholinesterase inhibitor? We talked about the drugs which can inhibit reversibly and irreversibly. If any toxicity happens with irreversible acetylcholinesterase inhibitor or reversible acetylcholinesterase inhibitor, we can give atropine as an antidote. So for acetylcholinesterase inhibitor, acetylcholinesterase inhibitors, we can give atropine. For both classes of acetylcholinesterase inhibitor, we can give for reversible acetylcholinesterase inhibitor, the reversible class, and we can give it for irreversible drugs. This was another indication of atropine. Okay, the duration of action of atropine is 4 hours. Duration of action for atropine is 4 hours. Now, maybe you will ask, you said that the duration of action for atropine is 72 hours. Yes, when we instill this drug to the eye, the duration of action will be 72 hours. But when we give it by oral route, or when we administer this drug systematically, the duration of action will be 4 hours only. Last thing we should know about atropine is the adverse effect of atropine. Adverse effect. Now you will know about the adverse effect. I am sure about it. When I was explaining about the action of acetylcholine on the M3 receptor on the gland, I told you that it can decrease the sweating, so one of the adverse effects can be hyperthermia. I told you that it can decrease the lacrimal gland secretion, it can cause xerostomia. These are the adverse effects. Some other adverse effect you can guess, but it's by its action on M1 receptor on gastrointestinal tract or gastrointestinal system. When it decreases the motility, so one of the adverse effect can be constipation. It can affect on the M3 receptor on the bladder also, and it can cause urinary incontinence. By its action on M3 receptor on the eye, it can cause blurred vision. These are the adverse effects, common adverse effect for cholinergic antagonists. So what are the adverse effects? The adverse effects are blurred vision. Another adverse effect is constipation, urinary incontinence. What about if it acts on M2 receptor of the heart, so the adverse effect can be tachycardia. Another adverse effect is tachycardia. It can increase the heart rate. Some other adverse effect when it binds to the muscarinic receptor, which are located in the central nervous system. For example, it can cause excitation. It can cause hallucination. These are the adverse effects of atropine. Okay, now we'll talk about some other classes of drugs which are in antimuscarinic drug. We can classify antimuscarinic drugs on the basis of their effect and on the basis of their indication. We can use some of these drugs for treatment of motion sickness. We can use some of these drugs for treatment of asthma and COPD. We can use some of these drugs for treatment of Parkinsonism. And we can classify antimuscarinic drugs on the basis of their indication. So what is the classification for these drugs? We can use them for treatment of spasm. So we can classify them as antispasmodic, anti-secretory drugs. For example, atropine is one of those drugs. Scopolamine is one of those drugs which can show antispasmodic, anti-secretory effect. So, what are the drugs? Atropine, scopolamine. As I said, we can use them for treatment of motion sickness, anti-motion sickness. So the drug here is scopolamine. We can use them for treatment of asthma and COPD. For treatment of asthma and COPD, the drugs here are ipratropium and tiotropium. We can use them for treatment of Parkinsonism, and those are anti-Parkinsonism drug, like trihexyphenidyl, and benztropine. And we can use them for treatment of overactive bladder also, urinary indication, overactive bladder, which we have lots of drugs in this group. You can remember them as I'll write here: soft bladder. S is for sulfenacin. O is for oxybutinin. F is for fostrodin. T is for toltrodin. And D in bladder is for darifenacin. These are the drugs which we can use for treatment of overactive bladder. Now we'll talk about the characteristic of each group and we'll compare it with atropine, which is a prodrug in this group. First we'll start by scopolamine, which have anti-motion sickness and it can show antispasmodic and anti-secretory effect also. Scopolamine, when we compare it to atropine, I told you that atropine has central as well as peripheral effect. I have peripheral action. It has central as well as peripheral action. But scopolamine only has peripheral action. It has only peripheral action, and we can use scopolamine for treatment of motion sickness, but we give this as a prophylaxis. We give this to prevent the motion sickness. We cannot give scopolamine for treatment of motion sickness. We give it for prevention of motion sickness. Another indication for scopolamine, if there is nausea and vomiting after the surgery, we can give this scopolamine for treatment of nausea and vomiting after surgery. Another group of drugs are the drugs which we can use for treatment of asthma and COPD. Ipratropium and tiotropium are there because they have positive charge. They cannot enter the CNS and they can show only the peripheral action also. Ipratropium and tiotropium are synthetic. As I said that this atropine, we can obtain it from blood donor. Have I written it? No, I have not mentioned it. We can obtain this atropine from a natural source. We can obtain it from alkaloid belladonna. Alkaloid belladonna. So this is a natural drug. But this ipratropium and tiotropium are synthetic drugs which have positive charges and they cannot enter the CNS. So they cannot show central effect and they have only peripheral effect. They can block the M3 receptor which is in the respiratory system. So the mechanism of action blocks M3 receptor. Block M3 receptor. And by blocking the M3 receptor, they can decrease the secretion in the respiratory system as well as they can cause bronchodilation. So they have approved for treatment of COPD as well as they have approved for treatment of acute attack of asthma. The difference between ipratropium and tiotropium is that tiotropium has long duration of action, so we can use this tiotropium once a day, but ipratropium has a short duration of action. We have to give this drug 4 times a day. This was about ipratropium and tiotropium. Another group of drugs in anticholinergic is anti-Parkinsonism drugs like trihexyphenidyl and benztropine. We can give these drugs for treatment of as adjunct therapy. First we have to note this. We give these drugs at adjunct therapy with other anti-Parkinsonian drugs for treatment of Parkinsonism. Another indication for these trihexyphenidyl and benztropine, one of the side effects of antipsychotic drugs is extrapyramidal syndrome. In extrapyramidal syndrome, we have Parkinsonism, and we can give these drugs for treatment of Parkinsonism due to antipsychotic drugs also. Next group of drug is the drug which we can use them for treatment of overactive bladder like solifenacin, like oxybutynin, like fosetrodine, like toltrodine and darifenacin. One of the common side effects when we use this drug is dry mouth. We have to keep in our mind this adverse effect, I mean dry mouth, is less when we give oxybutynin to the patient. We have transdermal patch of oxybutynin, and by giving transdermal patch, the dry mouth will decreases. We can see less dry mouth in the patient when we give these oxybutynin, transdermal patch. Another drug which is in anticholinergic drugs, we have the formulation, this type of formulation, I mean transdermal patch, is scopolamine. We have scopolamine as transdermal patch also. Transdermal patch. Okay, this was about anticholinergic drugs or cholinergic antagonists. Its classification, we classify them on the basis of the type of receptor they block: antimuscarinic drugs, ganglion blocker, neuromuscular blockers. In this lecture, we only talked about antimuscarinic drugs. In next lecture, we'll talk about ganglion blocker and neuromuscular blockers. In antimuscarinic drugs, the prodrug is atropine. We talked about the action, the indication, adverse effect of atropine. And we can classify these antimuscarinic drugs on the basis of their indication. We can give them for treatment of antispasmodic, antisecretory. Some of the drugs show anti-motion effect. Some of them show, we can use them for treatment of asthma and COPD. Some of them show anti-Parkinsonism effect, and we can use them for some of the drugs in this group, in this class. We can use them for treatment of overactive bladder. In next lecture, we'll talk about neuromuscular blockers and ganglion blockers.